Patient DM is a 42-year-old male who presented today for a TB test reading which was read as greater than 15 millimeters in duration. The patient shared that he recently returned home from a trip to India. DM denies fever, dyspnea, hemoptysis, and cough, and his physical exam was unremarkable. He does have a past history of generalized idiopathic epilepsy and alcohol use. A chest x-ray was taken and came back negative for lesions and cavitations. The patient also tested negative for HIV and hepatitis C virus. A basic metabolic panel and liver function test were performed, and all laboratory values were within normal limits. Treatment for latent TB infection will be initiated. It is recommended the patient start isoniazid 300 mg daily for 9 months. The patient should be counseled to discontinue alcohol while on isoniazid due to the possibility of increased hepatotoxicity and decreased isoniazid concentrations. Counseling should include taking isoniazid on an empty stomach, so at least 1 hour before or 2 hours after meals, as well as possible adverse effects including nausea, vomiting, and epigastric abdominal pain. DM also reports taking calcium carbonate 500 mg tablets, and these can decrease the absorption of isoniazid, so they should be taken at least 1 hour before isoniazid. Liver function tests should also be performed monthly to monitor for liver toxicity. DM is also currently taking carbamazepine for generalized idiopathic epilepsy, and he is well controlled, reporting no recent seizures. Since he's well controlled, we would like him to remain on the carbamazepine 300 mg tablets, 2 tablets by mouth twice daily. Now there is a major drug interaction between isoniazid and carbamazepine, which can cause increased levels of carbamazepine. Because of this, CBZ levels should be closely monitored and the dosage adjusted accordingly to remain within the therapeutic range of 4 to 12 milligrams per liter. The minimum toxic level for carbamazepine toxicity is 10 milligrams per kilogram. Additional monitoring should include CBC, including platelets and differential, reticulocytes and serum iron, renal function and electrolytes, and a complete urinalysis and BUN determinations. The patient should also be made aware of signs of carbamazepine toxicity, including slurred speech, tremors, and hallucinations. Again, the patient should be counseled to discontinue alcohol use to decrease his risk of liver toxicity and also be reminded of possible side effects, including rash, nausea, and vomiting. Additionally, the patient reports taking acetaminophen 325 mg caplets, because acetaminophen is also metabolized by the liver and can increase the risk of hepatotoxicity. It is recommended the patient discontinue acetaminophen. The patient is to be discharged home and returned to the clinic in 4 weeks. He should also follow up with the neurology clinic regarding his seizures. Thank you.